My name is Joe Weaver, and I'm here to talk about delirium. So let's go over delirium. What is delirium? Well, delirium is an acute state, so which means it's not supposed to last for too long. That it can be extremely hyper, and the hyper delirium we kind of recognize very easily because the patient is hallucinating, the patient is yelling and screaming, attempting to pull out their IV, attempting to remove their Foley, chest tube, whatever. They may be extremely fearful. They may actually want to hurt you or hurt their loved ones. They may use profanities that are not normal to who they are or who they were. Or delirium can present as a hypodelirium where they look depressed. So anything, I like to say, anything away from their baseline, consider it as delirium. So what does that baseline mean? It means a patient who you walk in the room, greets you, smiles, and is always very joyful. Now you come into the room and their face is neutral. They look fearful. Their hand movement, they're picking here, they're picking there. They look like they're very disorganized. They probably are. You need to recognize it early, get the nurse's attention, and say, this patient, my patient, is totally different than he or she was a minute ago, an hour ago, a week ago, a day ago. Report it. Now, why is that important, recognizing it early? Well, because it's treatable. So if you recognize it early, you get psych involved or the team, the medical team taking care of the patient, and we help get rid of the delirium. So how do you get rid of delirium? How do you cure it? Because, as I said before, it's treatable, it's acute. You treat it as a nursing assistant very easily. You interact with the patient. So you find out what the patient likes. So if the patient likes reading or eating, you help them with preparing their dietary menu that brings up what do you like. You talk to them about their grandkids if they have any grandkids. You talk to them about their life. Now, it's not really our job to realize at this moment when we're trying to get the patient out of delirium whether their stories are true. I've had stories from patients that they served the war and they were a hero, and I believed it, but then when I spoke to their family and got collateral, I realized that it was their own story that they like to tell. Do I care whether it's true or not? No, because my main focus, my main goal is to bring the patient out of delirium and interact with the patient. Another thing you can do to help get a patient out of delirium is keep them up during the day. Why is that important? Because if they're not up, if they're sleeping during the day, they're going to be very active during the night, and we don't want that. So yes, that means even if they had a very active night last night, and you think that they should sleep because the family says, oh no, they were doing this and they need to sleep, we still want them interacting with you, with reading, with crossword puzzles. We will have delirium toolboxes that goes around that you can actually work with them. Coloring, age appropriate, of course. Taking them down the hall if they have out of bed to chair orders or out of bed orders where you can walk them around. Also ensuring that they go to the bathroom regularly, that they eat their meals, that you encourage them, that you reorient them to where they are, who you are, because sometimes they don't know who you are. They can see you as a threat. They can see you looking totally like you don't. They can see you with horns and stuff like that. So very important with delirium is to talk softly. Do not speak in command form. Give them the reasons why they can't get out of bed. Well, you're weak on your feet. I don't want you to fall. Let me help you. Keeping the shades up in the room, even if they don't like light. Now, it's a fine line with delirium. Delirium is when the brain is sick. So anything that can be controlled in the brain, like how they see, how they speak, how they hold their tongue when they're upset, can be totally disorganized in the delirious state. So if they're not wearing their glasses, they can see things in the environment that looks like dangerous things. So make sure that they have their glasses. Hearing. So the brain controls the hearing. So if they can't hear correctly, they may hear things that are in the environment and hear them as threatening, become very fearful, and they may want to leave the hospital against medical advice. Not only does delirium affect how they think, it affects how they think logically. So they may want to get up, fall, they may think that they're in a hotel and you're holding them hostage. There's been many stories about a delirious patient, and your main goal is to work with them as a nursing assistant and to let the nurse know, the PA, the NP, the team, the medical team, that you think that your patient is going through delirium. Now, when the brain is sick and they have delirium, if we recognize it early and treat it with the interventions that I described to you, and getting psych involved very early, we can give them medications that can actually help delirium. So now we know that it can exist in a it can go mixed. So at one moment they're up and manic, another moment they're down and sad, and in between they can have elements of hyper delirium. Treating it is easy. First, you recognize it. Secondly, you do the interventions such as keeping the lights on, interacting with them, reorient them, having the psych team give medications that possibly can bring them out of delirium if the interventions aren't working. Why is that so? Because delirium is caused by neurotransmitters in the brain that are usually too elevated. So we give medications to reduce these neurotransmitters such as dopamine and bring them back to a normal level. Now, we do see sometimes that the medications that are prescribed as needed PRN are not given soon enough. Whether it's because you feel that you can get them out of delirium and you tried walking them and now you're making them more stressed and now they're ripping out things when you turn your back, or you let the nurse know and you let the medical team and they don't feel that they need the med right now because you haven't done enough interventions. So there is a fine line between allowing them to get to this hyper state when they may be only right there and not giving them the medications that they need. If the dopamine in the brain is too high and you don't try to get it down with, say, meds like Haldol, meds like Seroquel, and there's a host of other meds that we can choose depending on whether they're eating, depending on whether they're sleeping too much or they're too activated. That's the job of the psych team to determine which is the appropriate med. But we have to know about it. What causes it? Well, we already discussed that there can be some neurotransmitters in the brain that are elevated. There could also be an infection. Most of us know a UTI in the elderly population can cause their brain to be stressed, whether the bacteria is in the blood going to the brain or whatever's happening, whether it's a bacteria or virus, it's causing your patient to go away from their baseline. Labs. So their sodium can be low. Their potassium, their iron, anything that's taking the patient's normal homeostasis in their body outside and putting their body in stress has the potential to also make the brain be stressed and cause delirium. Change in environment can cause delirium. We don't know how that happens. Now, sometimes it can be because we gave the wrong meds as providers. They had anxiety, they were very hyper, and we gave them a benzodiazepine, something like Ativan or Klonopin, and we thought that would calm them down, and sometimes it does, but when it starts wearing off and metabolizing in the body, it has a potential to cause them to be more delirious, more confused, and worse, it can also make them very, very weak. So when they get up and you try to walk them, and they fall. So we want to use the meds appropriately. We also know that fractures, the inflammation process, can cause these chemicals within the body to reach the brain, and they can cause a delirious state. And sometimes operations using anesthesia can cause the brain to be delirious, or just too much stress. Just being in the hospital is stressful. Your sleep has changed. We're not keeping the shades up. They don't know night from day. They don't know where they are because we're not reorienting them, and their brain is already a little stressed out from being in the hospital, worrying about their significant others, their animals, their pets, and now their brain chemicals are all stressed out, and we need to fix that. And we do that. The most important point is to realize that delirium is treatable. It's not like dementia, where dementia has its ups and downs, and then it's neutral, but eventually dementia progressively is going to get worse. Dementia is not acute. Delirium is. So if we don't fix it at the earliest time, we put that person more at risk by length of stay in the hospital increases, by the potential of them doing risky behaviors when you're not watching them. It just makes everything worse. And the longer we keep a patient in delirium, the problem is they may not go back to their normal baseline. So what does that mean? If you have a patient, a loved one in your home, and you have family there, and they're pulling out things, they're yelling, they're violent, how can we handle that in the home? So we want to make them safe enough to go back home, back to rehab. We want them to get off of close observations and Q30s as soon as possible, so we know that when we do transfer them back home, they don't come back. Or when we transfer them back to a rehab, they don't come back, or they don't fall. So early reorientation, time, place, identifying who you are, walking them, keeping the lights on, wearing the hearing aids, wearing their glasses so that they can see is very important to delirium. Using the delirium toolbox that your nurse and your nurse managers and the site team gives you, interacting with them, asking the family to bring the hearing aids, their eyeglasses, any crossword puzzles that they enjoy. Getting them out of delirium is your job, is your key, recognizing it. When we have you in a room with a safety watch person or a close observation, jotting down what time they are manic, what time they are crying, how many times that they attempted to rip out their IV. Very important, because sometimes these delirious states can be cyclical. They can happen at 4. They can be a sundowning term that always after the sun comes down, they get delirious. Medications we can do with that is a simple medication like melatonin, but the most important job is you keeping those lights open and reorienting the patient. And that's really delirium in a nutshell. It's all up to you, and you can make a change. Take care. This is Joe Weaver, signing out.